Okay, hi everybody. We're starting a little bit late today, and new location, new wig, new hairstyle. It's all good. I am extremely excited to bring to you today Dr. Dan Nayot from Trio Fertility in Toronto, in Canada. And he is a world-renowned specialist, and I'm looking forward to bringing him to all of you to answer lots of your questions. I have a bunch here, and everyone please feel free to add in your thoughts and for some reason, Dr. Dan is having trouble getting in. This is sometimes happens with technology, as has happened before. I'm going to just talk for another couple minutes. I'll just continue talking to myself. Let's see if he comes on. If not, I will start again, and then we'll get moving. If anybody has any questions, I have a piece of paper here, and I can write everything down. He is here. I do see him, so hopefully he's going to come on in a second. So sometimes it just takes a while. Here we go. Here we go now. So there was one live, actually it was with Dr. Werner, who is a urologist, and it took us actually, I think it was 5 times.
Hey, it worked.
It worked. It's funny. I was just telling the viewers that there was one live. I know, here we are, technology. There was one live. I think it was a couple of months ago, and it was with Dr. Werner, who is a urologist, and it took us actually 5 tries to get this right. So this was only one. So I think we're doing well. Can you hear me?
We're ahead of the curve.
Yeah, we are ahead of the curve. Okay, you were frozen for a second. So but you're good now. Okay, perfect. Okay, so everybody, this is Dr. Frozen again. Frozen. You're frozen. We'll just keep going. See, guys, welcome to technology. You plan and you plan and you plan, and then
are we okay?
So you're frozen. Oh, now I see you again.
Okay.
Tell me how your connection is.
Better. I took my Wi-Fi off. Should be fine now.
Okay, fine. I was going to say that's sometimes what happens also when the Wi-Fi gets sticky. Okay, so guys, we're just going to start, because we never know how all things are going to be, and technology is strange, as we all know. So we're going to try. So I'm super excited to bring all of you Dr. Dan Nayot from Trio Fertility in Toronto, Canada. I know you have a bunch of other branches as well, and I am certainly not the expert on your life. So please introduce yourself to the audience, and then we'll jump right in.
Okay, nice to meet everyone, audience. I'm Dan. I'm a fertility doctor in Toronto, the home of the Toronto Raptors champions. I'm a fertility doctor at Trio Fertility. My first love was mathematics, but I have a Jewish mom, and I went to medical school. And then I became an OBGYN, where I was one of the few males around, and it turns out most of the males somehow end up going into the fertility field, and that's where I ended up. I did some training at Harvard, where I did my clinical epidemiology, so very into like statistics and academics. I did my fellowship out in McGill, and now I'm back in Toronto. I've been practicing about 6 years. Really love the academia, but a little bit too slow for me, and I turned that into this entrepreneurial spirit. So I'm really involved in the fertility startup world. Some stuff I've started my own, but helping connect people as well. So maybe we'll dive into that later on. But yeah.
Right. I was going to say, you and I had a little bit of a back and forth on email, and also beforehand. It feels like we should have a series of about 12 different lives to probably cover all of the different things that we need to cover in order to get through the breadth of your experience and all your entire professional life. But look, we have a bit of time now, so we'll do our best. Our best. Okay, so let's dive right in. I think, what's on the forefront of my followers, their minds and their lives, and so many others right now is, the world is sort of up and down in terms of opening, closing. Some cases, some countries, the cases are ticking up. We're obviously talking about COVID. Some countries, the cases are ticking up. Other places, the cases are ticking down. But in Canada specifically, and in the New York area, things are reopening or starting to reopen. So I wanted to hear from your perspective, what that looks like for your clinic, and what that means in terms of how you're scheduling patients, what kinds of things you're doing and not doing, etc.
So Ontario's doing really well. I'll give them a lot of credit. We have maybe 200 cases a day now, so everyone's feeling pretty hopeful. Also, Canada obviously is not as big as the US, so the fertility world in Canada is small enough where we can unify. So one thing we did really well is we all got together and said, like, we either all open together, we all close together and stuff like that. So it's kind of like a national wide, we can't get in trouble because we're doing it together kind of thing. So we're officially open probably even maybe for a month already. It is a clinic by clinic decision. At our clinic, which is one of the larger ones in Canada, we pretty much are doing everything. We're just doing it a little bit more cautious and clever. So some stuff is obvious, like we're screening people. If you've got fevers or coughs, you're not coming. We give everybody a mask. We check their fevers. We schedule everyone so it looks kind of like zombie land where there's not many people in the wait. We've staggered it really well.
Right, as opposed to like 300 people at 6 o'clock in the morning.
Right. Yeah. As a guy who likes the startups innovation, the silver lining in all this is it's forcing everyone to innovate.
Yes.
You always think, why does everybody monitor in the morning between like 7 to 9 where everybody has a job and has things to do? And yeah, so we're doing a lot of virtual, that everything we can, but essentially we're open. We are doing little things. We're all a little bit paranoid that, like, what if one of us gets sick and then the lab might close and things like that. So we're doing shifts in the lab. Pretty much, I'd say we're at 80% capacity, but just slower. But I think one amazing thing is you see a shift in patients for sure. Like everybody's, we're all on the same page. We're all like fighting COVID together. So everyone's been very supportive and helpful and just thankful that we're open.
Amazing.
Yeah.
Amazing. Are there, so effectively there aren't certain things that you're not doing? Like you're not saying to certain kinds of patients or certain procedures, we're not doing that yet, or we're not doing that now?
So on a grand scheme, no, but on the micro detail, yes. So one of the things we wanted to do is, I don't know how much people know of fertility on your podcast, but sometimes let's say when you do fertility treatment, some things are programmable and some things are not,
right.
Which means if I give somebody hormones, I can control when. So for example, embryo transfers, if you're on a program, I can make sure that you fall between a Monday and a Friday and not on the weekend. So things like that. So a good example is we don't do natural cycle transfers at the moment because we don't really have control over your cycles.
That makes sense.
Which makes sense, but very frustrating because there are patients who need it or want it, or that was the plan pre-COVID. But I think everyone's understanding. We think probably in a month or two, we should be back to normal.
And God willing, for everybody. Do you, someone asked before this about putting people on birth control in order to schedule things appropriately. And it's exactly what you were just saying.
Exactly
and right. Obviously, pluses and minuses and side effects and risks in regard to people being on birth control. Can you speak to that a little bit?
Yeah, I mean, one thing you'll notice, I mean, I don't know about the other fields of medicine, but in fertility, they say, 2 fertility doctors, 3 opinions. But, as a general rule, if you ask me, so first of all, why in the world do you go on birth control pills? There's 2 parts. One is scheduling. That's the truth. So, we can control how many people come off the pill on Monday and how many come off Tuesday. So we can stagger the waiting room and prepare the lab and stuff like that. That makes sense. Also for patients, it gives them a little bit more control, but it's really just for programming. We don't think it makes things better. Most will argue it definitely does make things worse, but if you dissect that, it's there's probably a subset of patients that probably shouldn't be on the pill, and I think that's the question you got. So people with a diminished ovarian reserve,
Right.
where we're already concerned we may not get too many eggs. Sometimes the pill, especially if you're on a higher dose or longer duration, sort of over suppresses the ovaries. So for those patients, we're kind of stuck a little bit. We either say, let's just wait till we don't have to use the pill, or we say, yeah, we're scared, but maybe the pill won't be so bad. Let's just see what happens. Or there's
Right.
other ways to program in the diminished ovarian reserve population, like called estrase priming or estrogen priming, which is very similar to the pill. So the pill is both estrogen and progesterone, and estrogen is just estrogen. But there's sort of ways to sort of synchronize the cycles. But it's true. It's caused a few things where we're sort of forced to do.
Do you what has been the most frustrating piece for you as a physician during this whole period? I'm hearing it from the patient side. They want to be in, they want to get the procedures done, at that specific time. They're desperate to have a child, and everything is out of their control. And this was, being able to get their treatments, or whatever piece of their treatments they were on, was sort of the only thing they could control. So I hear it from the patient side.
Yeah.
I'm curious to know from your side, as the physician side, from the clinic side, what was your most frustrating, what was the feeling from that angle?
Yeah, I think personally for me, the frustration shifts. Like what frustrates me is different at different phases. So at the beginning, it was like, what in the world is COVID-19 and how is it going to affect it? Like, does it, God forbid, is it kind of like Zika and we're going to have birth defects? So we're telling everyone to stop conceiving. That was the big fear at the beginning. Is it increased miscarriages? Just the unknown was really scary. So it made sense to just shut down until we understand everything. Now my frustrations include like having to follow certain policies, to like the birth control pills for everyone is a good example. Also, like behind the scenes, like you want to just start back at 100, but some people didn't have work for 3 months and they had to feed their family, and they went and found another job. And we have less nurses now, or people scared to come back to work for their own safety. You've got staffing issues, and things like that.
Wow. Yeah, those are all right. All pieces that patients don't think about. I mean, obviously they're thinking about their own safety. They're thinking about the safety of their physicians and the clinic and so on and so forth. But right, the staffing issues and all of those pieces, right, is something that, yeah. Do you think, I mean, so your hope, and in terms of the way Canada has been progressing, your hope is that you will be, as you were saying, that you will be back at 100%, and that these specific limitations will not be in effect anymore.
Yeah.
Is that a feeling across the country, or is that more your clinic and sort of the cases that you're seeing and the people that you're seeing?
No, I think the word on the street is everyone's about 80% capacity, because staffing's a bit of an issue, and patient flow and things like that. But I think everyone's feeling optimistic, but still cautious, right?
Okay.
Yeah.
Thank you. I felt like it was important. We're going to jump around now and talk about a few other different topics not related to this, but I thought specifically because this is, in forefront of everyone's minds and people are starting back, so that I really wanted to address this piece with you first. So thank you.
No problem.
Okay. So the other piece that I wanted to get into, and then we have some other questions as well, is talking about what happens sort of when fertility, your fertility treatment, or the doctor that you've chosen, the clinic that you've chosen, it seems to be not working, or you're not getting pregnant, or you're not getting the results that you hoped that you were going to get. What does, from your standpoint as a physician, obviously, you can't speak to the individual patient. I think everybody comes in and sort of has the expectation, everyone says like, oh, just do IVF and you'll have a child. Like, and obviously, you and I know it doesn't always work like that. It's not always, sort of one and done. But speaking from your side, what is the point where you say to yourself, or you say to your patient, we've done everything we can, and maybe time to try another method, another physician, go get a second opinion. What's your process like?
So are you asking when I recommend for my patient to go somewhere else, or when do I recommend for someone else's patient to go somewhere else?
Both.
Okay.
Let's
So,
do both.
okay. So for me, I think, I mean, there's the science and there's the EQ and being able to, feel someone across the room. If someone's lost your trust, not just you or your clinics, because a few mishaps have happened, somebody didn't call them back, or the list can go on and on.
Right.
So if they lose their trust, if you see that hope is gone for them, because then I think even if it's the same approach or even the same medications, but in a new environment, I think it's a good idea. So sometimes forcing them to be with it, like that's number one. So I think when I can't say there's too many times where I feel like there's, so to me, that's number one. If you feel like you've lost the trust of the patient or the hope of that patient is gone, they need a fresh start. And sometimes I say
psychological break.
Psychological, or they can't come into the room upset or angry. They need to be hopeful and optimistic, which everybody has. But when that happens, you need to change the environment. So sometimes I say either stay in the clinic because your embryos are here, for example, or your chart's here, or I can advocate for you. You'll get that second opinion really quickly. Or sometimes I say you honestly need a brand new facility, new lab, new faces, new work flow, and I think that's super helpful. But whatever you do, don't give up. Just keep going. Sometimes I'll ask people to get second opinions for things that we don't offer, like at our clinic. So these are usually things on the fringe, which isn't a bad thing, but sometimes in like the autoimmune sector of things, or super experimental stuff. And I say, like, if I was me, I maybe I'd give it a shot. I just can't offer that here. I from the patient perspective, I mean, I see tons of second opinions and third opinions, and I'm sure I have patients who go for second opinions. I'm not oblivious to that. But the one thing I see consistently is like miscommunication. Like the patients that I see almost aren't sure what test they did or what was told to them or why. And when you just spend the time and go through the numbers and the logic and the patterns and the chart, their mind are blown. Like no one's even told them that it was, you have a thin lining. No one's mentioned that. No one's mentioned that they said sperm's fine, but they didn't really go into the details and things like that. So I think people really appreciate transparency and attention to detail. I don't know. I think that's one. I think whether it's right or wrong, I see I see physicians who are at the mindset, it may take a few tries, and they try the same thing several times, which you can argue isn't the wrong approach. Right. But from the patient's perspective, I think they don't have the same hope of trying the same thing if it didn't work last time. Even if you can change one variable, it gives them hope. So I think that's one that I see where they say, like, my physicians keep doing the same thing, or they're not digging deeper into more diagnostics or not trying anything unique. Whether that's right or wrong is a different topic, but those are common reasons I see second opinions. Of course,
it's the old adage of, fool me once, fine, fool me twice. Like almost like, not necessarily that it's a bad idea, but you almost feel like if this didn't work the first time, like something has to give the second time. It just psychologically makes sense. Even as you said, medically, even if it's not the wrong approach, it just psychologically makes someone feel better if even one small thing has changed.
Right. So I find that, there are clinics that are very regimen, which is probably good for quality control and things like that. And some patients just don't feel good about that. They say, like, look, my second IVF was the best, and we tried this and this and this. Why can't we try that again? And we say, okay, let's try it.
Right. Do you think that, I mean, like when people sort of, like, one of the questions I got was about unexplained was about unexplained infertility. And so when you're sort of shooting in the dark and you don't know exactly what it's going to be, how do you, like, to go from one clinic to the next clinic to the next clinic, like what does that look like?
Yeah. Okay.
And I'm going to
So
let you talk for a minute so I can go get a cup of water because I have a little frog. So talk.
I need 30 minutes. You can make yourself thinner.
Exactly. Go ahead.
Okay. So in terms of unexplained, so first of all, what in the world is unexplained? So unexplained is a term we use where there isn't something obvious that we can measure. We simplify it into a few things. If we think you ovulate perfectly well, and your tubes are open, and your uterus is normal, and your sperm is fine, then you're unexplained. Some people go a little bit deeper than that, but a few very important points. The first one is, in the world of fertility, there are very few things that are black and white. Black and white for me is like, for sure, because of this, then that. So you're in menopause, yeah, you're not getting pregnant because your ovaries are not functioning.
Right.
You have blocked tubes or you don't have tubes, sperm and egg are not meeting. There's erection problems and you can't have intercourse, sperm and egg are not meeting. You're born without a uterus, you probably can't carry a child. So those are black and white, and they're actually not that common.
Hold on. Probably?
Yeah, you probably get a uterus transplant these days.
Okay, fine. Right. Okay. I'm just, just
So,
wanted to make sure there was something I wasn't missing there.
so the rest of it, though, is gray. So the gray is where we all live in. So sometimes physicians and patients, we're very reflexive. So we do a whole battery of tests, and anything that's a little bit to the left or the right, we circle, and we just assume that's contributing to the problem. And maybe it is, and maybe it isn't. So, I can't tell you how many times, my thyroid is a little bit low, and everyone thinks it's always the thyroid. And I'm not saying it's not the thyroid, it's not contributing, but we don't really know that the whole issue is related to the thyroid, right? We've just identified that something is a little bit off. So that's the first thing. I tell patients, we don't jump at a single number. We look for patterns and we use logic, right? So, here's a good example. So let's say unexplained primary infertility means someone's never been pregnant before, okay? And let's say it's been 4 years and never been pregnant. What I say to them is the following. The only thing I know for sure is an embryo has never implanted into your uterus. If it did, you'd miss your period, you'd have a home positive pregnancy test regardless of the future outcome. So that's the only thing I know about you. What I don't know is where in the process inside your body is the bottleneck. It could be anywhere from like the egg is stuck in the follicle to you have a perfect embryo every month but not implanting. I have no clue. I just know. Okay. So now we go through IVF, and there's several scenarios that can happen. But let's say, you got 12 eggs and you made no embryos. Devastating. It didn't work. We don't even have an embryo to transfer. I have some insights for you. I think the problem is in the seed, not the soil. We're dealing with an embryo. It's not related to your uterus or implantation or progesterone or stress or things like that.
Or that you don't know if that part is an issue yet because you haven't even gotten to that point yet because you're not creating, you don't have an embryo to implant.
You're right. It might still be also an issue, but for sure we've already identified. So these are that's the way we sort of approach it. You look for patterns and you look for logic and things like that. If you have, 18 eggs and you've split them, and half of them you do traditional IVF, you put thousands of sperm around each egg, and half of them you do sperm injection, ICSI, and all of them fertilize and none of them fertilize, you say, I think I found, statistically speaking, this isn't just bad luck. So I think unexplained, at least, yes, you may not know the exact answer, but you can at least logically, I always sort of talk about a triangle. Do you think it's like egg? Do you think it's sperm? Do you think it's uterus? Where do we think the problem is? And I think at least you get to focus on there. In each one of those, we can dig a little bit deeper, but I think the key is just like patterns and logic.
I think that was actually one of the clearest ways I've heard anyone explain just the entire process and sort of where things can go wrong and how to break it down from there. That was phenomenal.
So the is like, if you've got a whole bunch of perfect embryos, whether those are tested embryos or high-grade embryos, and it's not implanting, at least you can say, you know what, I don't think it's an egg sperm problem. I think we're missing something in the implantation problem.
Right. It makes perfect sense, but it was beautifully explained, absolutely beautifully explained. And then one of the other questions was, if you're making embryos, but they're getting to day 3 and not getting to day 5, then the assumption based on exactly what you were just saying is that it's more of a genetic issue. We're obviously not even talking about an implantation issue because you're not there yet. It's some sort of genetic issue that's going on between the egg and the sperm, whether it's one or the other, I'm not sure. I mean, maybe you could speak to that, but it's that the embryos are being formed, but they're not being allowed for whatever reason to grow further to mature.
Yeah, I think that's a really good question because it's what we learn. Like we learn that, you know, in our training, and it gets disseminated all the time. But if you really look at it, we don't actually know. Like, so, you know, we try to simplify it and say like, all right, day 1 to day 3 is sperm related, and then day 3 to day 5 is egg related, or the reverse. And you'll see people saying that, you'll see people saying that. The truth is we don't really know that much. I don't want to be eggist, if that's a word, but you know, in reality, like sperm is much simpler than the egg. You know, we're talking about millions of sperm, and we see sperm as, not to belittle it, but it's like a vehicle to get the chromosomes to the egg, where the egg is, you know, takes all month to grow. It has all the mitochondria. That's what's dividing. It's a critical piece, and that's why we talk about the biological clock for the egg, but not the same for sperm. So maybe I am eggist, but I think the egg is a more complex variable here.
Yeah, go ahead. Sorry, I didn't mean to interrupt.
I was going to say, I can't talk in generalities like that, but in general, the egg is more complicated than the sperm.
So I mean, but the reality is that for someone who's at least getting to day 3, it means something is working, but something is also not working, and it would have to be sort of dug. I mean, I'm guessing just based on my limited knowledge that for someone like that, there would have to be testing involved. And I mean, someone's even asking here, at what stage do you offer testing, or would you offer testing?
So I'll just talk about the day 3, and maybe it's getting too detailed, but again, these are just my opinions. But once you have a fertilized egg, it almost automatically grows to day 3. So good or bad, you very rarely see a drop off between. That's quite actually rare. So if your eggs arrest at day 2, all of them, something very unusual is happening. That's an interesting scenario. Day 3, so almost automatically they get to day 3. So when we hear about day 3 transfers and it didn't work, we really don't know that much about the embryo. It could have arrested as soon as it went into the uterus. So day 3 embryos, but not blastocysts, to me, it's almost a not blastocyst, because a fertilized egg almost automatically makes it to day 3.
Okay.
Yeah.
Okay. That's I mean, I think that's something I didn't know, and I think it's very good information for the audience also, just to sort of put in the back of their minds.
So if you even gone through IVF and who's seen their charts, but if you go back to your charts and look at which egg fertilized, I'm not saying 100%, but large significant will be day 3. What happens from there on is another discussion. So some people talk about doing a day 3 transfer. I don't know if I'm going off track here, getting too scientific.
No, this is good. Go ahead.
So some say, listen, my embryos always arrest on day 3, and maybe I should do a day 3 embryo because they're gonna arrest in the incubator. So do you think we should do a day 3 in my scenario? So again, my opinion, I think probably 20 years ago we would say we didn't have the technology to really like nurture embryos to blastocysts, but now it's pretty standard of care. You don't need to be at New York's best IVF clinic. It's like every standard IVF clinic can do that. And you know, they've done studies exactly on this situation. So if you've got one embryo on day 3, what should you do? Should you put it in? Should you wait till day 5 and put it in, but maybe it won't get there? Should you wait till day 5, freeze it, and then put it in the next frozen embryo transfer? And the outcomes were the same. And that's, so the way we sort of look at it is, if it wouldn't have made it in the incubator, it probably isn't making it in the uterus. Because if you thought the uterus was a better incubator, then why not just put it on day 2 or day 1 or anything? So that's sort of a more philosophical discussion. So some patients and doctors say, put it in my uterus and give me a chance. And some people say, keep it in the incubator. Don't put this poor patient through a transfer and false hope and things like that. And at least give her information. Because when you put that day 3 and it doesn't work, our wheels start spinning. Do I have an autoimmune issue? Are you sure you checked my thyroid again? Things like that.
Right. Is it a uterine problem, a lining problem, a progesterone problem, et cetera, et cetera, et cetera? Right.
So I
Yeah.
obviously I want success, but if it's not going to succeed, I'd love to at least be able to tell people something.
I mean, that makes perfect sense. At what stage, someone's asking, at what stage do you offer genetic testing? I'm assuming, I'm going to go, I'm assuming obviously all patients, when they come to your clinic, you know, they're going through initial genetic testing, blood testing, but I'm assuming that this person is asking specifically about embryo testing.
Right.
I'm going to assume, I don't know.
Yeah, so you're right. Those are two different things. So genetic testing for the mom and dad, or the female and the male, is just about, do you have a rare gene that the counterpart might have and then the child might have? That's a different scenario.
Yep.
And are you going to test these embryos for chromosomal problems? So as we get older and embryos get older, more and more embryos are chromosomally abnormal. So, you know, the whole world of chromosome testing is another complex topic. I mean, and we can spend an hour of the pros and cons and the controversies. I can tell you
That's our 12th session. Yeah.
so the pendulum is swinging all over the place. So I think, I guess I can tell you mine. So for me, some of the cons include price, obviously. Some of the cons of testing is, you know, so we believe the technology is really, really good. No one's questioning the technology. The problem is you're taking if you think of like I don't know, a BlackBerry, you're taking a few little pieces out and checking those cells. So the information you have is on the cells you took. So you are assuming those cells represent the whole embryo, and you're making godlike decisions. You're saying, this will never work or be a miscarriage. I'm saving you from this. This has the potential to work. Okay. Just from a mathematical, that's my background. You can argue whenever you do PGS or PGTA, at best, you can't be improving the cycle success because you're taking away embryos. You're not putting forward embryos. Sorry, I don't think I explained that well. Let me go back.
Yeah.
When we talk about IVF success, this is an important point. When I talk about success to a patient, will this IVF work? We're talking about cumulative. It means when you finish all your embryos, did you have a baby or not? So if you go through IVF and you got 10 eggs and you have 4 embryos, and the first didn't work and the second didn't work and the third didn't work and the fourth works, I'm fist pumping and I'm saying 100% success rate. What a smart doctor. And you're joking, right? That took me 9 months and 4 transfers and you're 1 for 4. So we talk about it differently. So if you're talking about chance per success for IVF cycle, genetic screening by definition is going to remove some embryos. So it can't possibly improve your per cycle rate. Okay. But usually what we're talking about is per transfer rate. So that's one huge misconception I see from patients. So it's true, or the evidence is pretty strong, that if you have a screened embryo, your success rates are higher and your miscarriage rates are lower, but it wasn't the testing that did that. Right? Like what would have been is how we think. So it's not that the PGTA gave you a higher pregnancy rate or anything like that. We sort of use it as a form of efficiency. So a really good example is, I don't know how it works in New York, but I'm imagining people have to pay for IVF.
Someone has to pay for IVF. Some insurances cover, but you know, other times, you know, it's private patients that are paying for it. Yeah.
Not unrealistic that a patient only has the funds for 1 attempt, right?
Correct. 100%.
So actually, I'm going to zoom out again. 2 types of reasons we go through IVF. There are patients that without IVF don't really have them a chance. They need IVF. A good example is your tubes are blocked, sperm and egg are not connecting, you need IVF. And there are patients, unexplained is a good example, where we think IVF, we're saying it could happen any month and we're hoping the best for you, but IVF is really going to increase your efficiency that cycle. So let's talk about the group who needs IVF, and let's say they can only afford 1 cycle, which is a very reasonable assumption. For that couple, I probably will say, I think I would use every embryo that you have and hope for the best, because me testing it isn't going to give you extra chances.
Right.
So that's a good example.
Because we want to give you the maximum possible chances, and why not just put them all in and let's go. Right.
If there's even 1% of a false positive that I took away, then I've diminished your potential at the end of the day. But again, it really depends. So patients who've had multiple miscarriages, whose focus is, I want to minimize my miscarriage risk. All right, let you fail before you even put it in, sort of thing. Patients who we think may only get 1 or 2 embryos, and cost is always an issue, they say, put those 2 embryos in and let's see what happens. If I'm going to get 8 embryos, yeah, save me from like 6 months of heartache and transfers. Go ahead and screen them. So there's like pros and cons, and it depends. So I don't even remember the question. I think the question was, at what age should you test them? I think most studies will suggest, it goes on logic. So again, the younger you are, the higher percentage of embryos we suspect will be normal. We don't know for you, but in general. And so if you're like under 35, we sort of say like probably a third to half your embryos would be normal. You'll get there soon enough. Why test it? If you're, 38, 39, 40, and we say, listen, maybe only 1 in 5 embryos here are going to be normal, you may want to test those embryos, especially if you're going to get a whole bunch of them.
Right. I mean, and that makes perfect sense. I mean, it's interesting. The original question, just to go back, was at what stage would you offer genetic testing? And then the person wrote back, actually, she was talking about the parents, not the embryos. But I mean, we covered that too, because we started off by saying,
well,
initially when someone comes into your clinic, and this is standard for any IVF clinic, they immediately get genetic testing. Correct me if I'm wrong.
No, I'm not sure that's true. It depends
Not
where you
sure.
are.
Okay.
No.
Please correct that. That's why I'm bringing you here. I'm
Yeah.
not the expert.
So, if you go by guidelines, they sort of say to check certain population groups. So, a famous one, like Ashkenazi Jewish population or French Canadians, because there's a higher risk of certain genes. So most people follow that guidelines. A lot of people are proactive, and you say, like, you don't know, a few percentage of the population are going to catch something. Like, do you want to do this test? It's a few $100s. Here's a panel of 250 genes. Not everybody does it. I mean, there's so much to cover in one clinic that sometimes your doctor forgets to talk about it. But I mean, nowadays you can order that stuff to your house if you're interested.
Right. I think for me, as someone who's Ashkenazi Jewish, for me, I was immediately offered that testing right away. So I just assumed that that's offered to everyone right away, which is clearly not true.
Right.
Not true. Okay, let's go through. We have a few more minutes. So let's go through another. So someone was asking, do you advise against the day 3 transfer? And you answered that already, for a number of different reasons, for different types of patients, for different amounts of embryos, for risk profiles in terms of miscarriage, whether they're more risk adverse or less risk adverse. I mean, you already answered that beautifully.
As no, I let him grow to blastocyst because I think I'd rather know the true information, but I wouldn't, I wouldn't force someone to do that. If someone's adamant about it, or that usually happens because once you did a day 3 and it worked, then yeah, sure, let's put it in.
Absolutely. Okay. So someone here is asking about, well, okay, I'm going to do this one question very quickly because I think this is an easy answer that you gave already. How do you explain quote unquote good embryos that were already tested that end up in miscarriages? And I'm going to assume, based on everything that you've said already, that at that point, being that we think that it's a good embryo because it's been tested, then therefore it's not an egg sperm issue, it's a uterine issue or a hormonal issue, it's something on the other side. Is that, am I answering correct?
And all logical sort of, now you're using my playbook, yeah. But it's true. So my mind immediately goes, so maybe it's not embryo related, maybe it's something about implantation related. Although one thing I do tell patients is there's 3 ways to evaluate embryos: how it's developing, nice and symmetrical in certain days, what it looks like visually, so the grading system you might have heard of 4AA or 2BC or something like that, and the chromosome. So all 3 of those give me an indication. But I sort of tell people, listen, normal chromosomes is a prerequisite, but it's not the only thing we need. There might be a lot of things in the embryo, like mitochondria, that we can't really test for. But yeah, my mind goes to maybe it's not embryo.
Okay, perfect. Okay, there's someone here asking about testing after recurrent miscarriages. At what point do you intervene? What kinds of testing? I mean, obviously that in itself could be an entire hour topic. I know as someone who's also had multiple miscarriages, but can you, give us a minute and a half?
Could you,
I feel bad about trying to,
no,
trying to constrain you like that, but
you
a
allowed
little
to,
bit here.
are you allowed to share your story, Amy? I'm assuming you
I,
share.
I yes. Most of my followers know already, but I'll share it again now, just by way of context. In the early stages of our fertility journey, I had an 8-week miscarriage, which ended up being a blighted ovum that was a trisomy 16. But then after my third child, I had 4 second trimester losses in a row, all that were at 16 or 17 weeks, and they were unexplained. We did thousands and thousands of tests and doctors and dollars and so on and so forth. But that's my story. I'd love to hear how, yeah.
Did they ever find potential?
There were theories. There were no answers. This was between 2009 and 2012.
Yeah.
So it's possible that if this was happening in today's day and age, we might have an answer. But at that point, there were not.
So that's a good comment. Like this field, like the reason I got into this field is like it's so new. If you think about it, like the most miraculous thing we could do, which is like the best thing we can offer now, is like IVF, which is incredible and done all over the world, is like 40 years old. Whereas like we've been treating pneumonia for like 2,000 years. So I got into this field because I wanted to be part of the change, and it's like rapidly changing. For example, I'll tell you one of the interesting, exciting things that are happening now. One of them is they used to think that the general thinking was that the uterus was a sterile environment. You have this cervical mucus plug and nothing goes up the uterus. But if you think about it more closely, you think, oh, that doesn't make sense. Our skin is full of bacteria, our vagina is full of biome, and when it's off, we get yeast infections and BV. Like there's got to be, that thing has to keep going up. And it's because they were used to do like old school swabs, and now they have the technology to check like viral RNA, and they say, whoa, it's far from sterile. So the whole world of like uterine microbiomes and uterine infections, and these are not symptomatic stuff. It's not like pus and pain and fever. This is like, oh, you didn't know about it the whole time. That's one exciting field. So like that didn't exist 10 years ago. I'm not saying that's the cause, but there's so many things like that we didn't know. So what is my approach for recurrent pregnancy loss after a baby? Was that the question?
The person didn't say anything about whether it's after a baby. She's just asking about testing after recurrent miscarriages.
So you brought up something really helpful. So you had a blighted ovum. So for the people on the podcast, it means on the ultrasound, we can see a gestational sac, which is the first part that we see, but that continues to grow, but nothing inside. It's not a really nice term, but that's what we call it. And you actually tested it. That's not very common, but I wish it was. I think people don't know that you...
I tested because as a physician, I need answers. So I wanted answers. And I also went through, instead of having a natural miscarriage, I had a procedure. I had a DNC specifically to make sure that we got tissue that could be tested. So, yes.
So nowadays, it's a relatively straightforward test and accessible to patients, but still 90% of people I see had no clue that was an option, and they wish someone told them, because that really helps us. So for example, if somebody has a miscarriage and we got the chance to test it and we find out it's a chromosomally abnormal, we have an answer. And I say to them, look, it's not because you didn't have progesterone, and it's not because your thyroid flared up, and it's not because you ate Chinese food, and it's not because you had sex, and it's not because you fought. This was predestined from the beginning. And I think that's really helpful. What you do about it next.
Extremely helpful. It's extremely helpful psychologically for everyone I see. Yeah.
I don't barking up different trees. So I don't think patients know that, but you can probably get that to your house. Like there's a lot of companies out there that like they'll send you the kit to your house. I mean, you may have to handle the miscarriage yourself, so not everyone feels comfortable with that, but Or if you're going for the procedure, you can either bring the kit or make sure they have the kit.
Yeah. Amazing. I didn't know, but I guess the question is, so I mean, this specific person was specifically asking about recurrent miscarriages. What is that look like in terms of the testing?
So right. So I started because one is like, did we already test the miscarriages? Because if we tested them, we have answers. We sort of know where we're heading. If not, what kind of testing do we do? So we sort of break it up into the general fertility workup, what everyone might be familiar with, like a diagnostic cycle and a sono ultrasound and looking for fibroids and polyps and scarring, and sometimes it gets a little bit deeper in the recurrent miscarriages. There are things like having genetic predisposition to microclotting or autoimmune problems or an underlying chromosomal problem. And I mean, the list goes on and on. But this sort of goes back to the beginning of the discussion, which is you've got to take everything into clinical context. So just because you found something and you circled it, it doesn't mean that's the problem. Okay, I want to find a problem. The patient wants to find a problem. We want to attack it. We probably will blame it all on that thing, but we don't really know that.
I mean, yeah, I can personally say from my own perspective that I had, every single test that you mentioned, plus about a gazillion more. And we went to doctor after doctor after doctor after doctor, and each one had a different approach, which is exactly what we needed at the time because I was looking for answers. And we didn't find them. But this is not about me anymore. And this is about trying to help as many people as possible. Okay, I'm now scrolling here, and there are, go ahead. I'm sorry, go ahead.
For unexplained, I say two things to patients. One, I was like, unexplained means I can't measure it or see it or quantify it. So it's got to be microscopic, receptor mutation or gene defect, the list goes on. And the other thing I tell people, it's like, it's unexplained in 2020, but in 2030, we might have an answer. Yeah.
Right. It's exactly what I always said to my doctors. I said, please, I said, if you come up with something, come find me again. I'm happy to give you tissue samples, blood samples. I'm happy to add to science. Okay, Dr. Nayot, I have, dozens and dozens and dozens of questions here that are extremely specific. And it's clear that we're not going to be able to do them justice here. So obviously you and I need to talk again, and you and I will schedule that offline, and we'll come on and work on another topic, and we can either open it up to everyone, or we can, make it more topic specific. But I guess my question for you is now, if someone has a specific question, or if people want to schedule a telemedicine appointment with you if they live in the States. So the majority of my followers live in the States or live in other countries. Yeah. Is that something that your clinic is doing, or are you solely doing, people that you see, that you're seeing locally?
Yeah. So my comment is, yes, we're doing telehealth, but truthfully, I don't think it's as efficient or useful to anyone if I can't see them. So, if I speak to you by phone, I get a lot of information through the details where I'll be talking about, and I'll base it on the chart you're going to give me, but I don't get to see your ultrasound. I don't get to, if we wanted to do more diagnostics, logistically, that's such a complicated thing. So, I'd love to think that I was like the best physician that you need to fly, come see me, but I'm sure you've got some local great physicians. I'm always happy to give my opinion on what I see. I just don't feel like it's the same as if you lived in the city and we can actually, if we think we found something, go a little bit deeper.
Yeah, look, I mean, that's exactly what physicians everywhere are saying now, that telemedicine, where everyone is grateful and thankful for the fact that telemedicine exists, because otherwise we couldn't, handle patients at all, especially in this time period. But it's certainly not the same. It's not the same at all.
Yeah.
Okay, look, I'm incredibly grateful for the time that you spent here. I know that you're very busy, and your patients, one of the things we didn't talk about at all is the artificial intelligence piece, the entrepreneurial piece, all of the fertility, the fertility business side that I'd love to hear about at another stage. But I wanted to bring you on here because there are a number of different general topics that I knew that you were really great at describing, and people really relate to the way that you communicate and discuss different aspects of fertility. So I'm grateful for you coming on here, and I hope that we can do this again sometime soon.
Come anytime. Thanks for having me.
Thank you. Okay, guys, have a wonderful night. Thank you for being here. Look, I wouldn't say, and I think that this is what you would say to the audience, wouldn't say that people shouldn't reach out to you, but know that there are limitations that obviously cannot replace the in-person visit.
For sure.
Okay. All right. All right. Good night, everybody.
Okay. Good night. Sleep well.
Good night.